So part 3 of postpartum today, we're going to go over pelvic organ prolapse, diastasis recti, some self-screening tools for both, some symptom management, as well as some general core strengthening for the postpartum population. So first off, pelvic organ prolapse. What it is essentially a descent of one or more of the pelvic organs or structures that fall into or through the vaginal canal. So if you think about, I tell people thinking about pantyhose, right? If this is the vaginal canal here, all your organs sit inside here. And what happens following delivery or weakness or surgery or anything of the sort we'll go through is the walls here get thin, and then you get a little bit of an inversion of something or something falling through the wall of the vaginal canal. So prevalence, 1 in 5 women in the United States have a pelvic floor dysfunction, and 3% of that, of those women have pelvic organ prolapse. It's not as common as urinary frequency. I'm sorry. Okay, my laptop's being funny. Is it back on? Okay, so I did a quick poll. So in 2017, there were 165 million women in the US. 3% of that puts us at 4.95 million women who suffer from pelvic organ prolapse. So that's a good amount of people to kind of think about. So risk factors and causes. Age, race, ethnicity have been proven to be some risk factors, as well as obesity, just because there will be extra pressure and gravity kind of pulls one way as well. And childbirth, so vaginal birth versus C-section, as well as multiple births and trauma. And looking at increased intra-abdominal pressure. So this kind of goes back to, from a female perspective, if there's prolonged pushing, if forceps were used, if all of those cases happen during a vaginal birth, there could be some nerve damage, there could be some tissue damage, which causes a decrease in muscle tone or laxity in tissue. As well as in men, there could be heavy lifting, men or women. Heavy lifting is a really big one where we hear about the Valsalva a lot. And don't get me wrong, Valsalva has their place if the person is bracing their core correctly. However, with novice Valsalva maneuvers, what happens is, if you guys remember from Q's slides, there's a lot of pressure coming down this canister. The walls here aren't necessarily strong enough, and if they are, then they push in, there's pressure here, and your pelvic floor on the bottom does not generate enough force to push back up. So now you have a descent of some structures from the pelvic floor. Menopause, just because there's a change in estrogen levels. Estrogen is very prominent in women, and when there's a decrease, we look at tissue change, and if tissue thins, then there's a dexterity difference in tissue intensity. And then pelvic traumas and surgeries, like we spoke about, such as hysterectomies, C-sections, and all of those things, sometimes may play a role, as well as connective tissue disorders. So Marfan syndrome, Ehlers-Danlos, increased hypermobility that is congenital can lead to increased risk for pelvic organ prolapse. So, okay, sorry, really quick. If you take a look at all of these right here, this top left photo shows all these shows a side view. However, this one is in anatomy without prolapse. So just really quick, uterus, bladder, vaginal canal is this thin red line right here, urethra, and the vaginal openings right here. Okay, this is the rectum, this is the anus. Now, with no prolapse, everything stays within this line. So if you look at a cystocele, that is a descent of the bladder. So the bladder comes forward and it falls into where that vaginal canal was. And some people will see a bulge in the front, what we call an anterior prolapse. There'll be a rectocele where the rectum, again, the back wall here, falls forward. So the anus is still here. It is falling forward into the vaginal canal, and there's a bulge there. There's also uterine prolapse where the uterus itself, so if you look at this, it's kind of looking like a golf club, where the uterus itself, because of increased pressure or what have you that has happened, has now come down, descended into the vaginal canal. There's an enterocele where we talk about a gap that has happened, which allowed the intestinal lining to fall through, and then a vaginal vault where there's an inversion. Okay, so pelvic organ prolapse, the signs and symptoms. Majority of the time, patients will come in talking about vaginal pressure or discomfort. A big one is feeling like there's a bowling ball or something that's in or at the vaginal opening. There's a protrusion or an actual physical bulge. So if you look at the picture on the right, this is actually a cystocele where the bladder is falling forward. Okay, and if you open the vaginal canal and you have this person push, you'll see this bulge that comes out. This is the urethra. The vagina is still there, okay? It is just now just kind of taking the place of it. You could essentially go in and move it, excuse me. So some other signs and symptoms will be positional changes to start or complete emptying, whether it is urinary or fecal. So some women will talk about, well, I can sit here and go, but at the end I kind of have to bend forward, or I have to push at the lower abdominals, or I have to lean back. So depending on what the anatomy is and where everything is, those can be some signs and symptoms. There's feeling of incomplete emptying. So again, if the bladder has fallen into the vaginal canal, you can see how there would be a pressure change in how urine is flowing out of the urethra, where now there's lower pressure here. You'll still feel the fluid, but there isn't enough pressure to generate it out unless you push or something of the sort. Urinary changes. Urinary incontinence, stress or urge are some signs. Frequency and urgency, because there is increased heaviness in that region. Post-void dribbles. So if you notice that you go to the restroom, you sit down, you go, and you feel like you're pretty empty, and you clean up, you stand up, or even in the middle of trying to pull the bottoms up, there's a little bit more that comes out unknowingly. That is a potential sign. There will be some sexual changes as well. Doesn't happen to everybody, but there could be pain with penetration, difficulty with orgasm, sensitivity in the vulvar region as well as the vaginal canal, things to again keep an eye on. Lower back discomfort as the day progresses. Some women will talk about they feel fine, and if they've stood too long or they've done a lot of heavy lifting, they'll feel increased lower back pain that's a little naggy with the pelvic bulging or heaviness that relieves itself with sitting or generally laying down, okay? So self-screening. I'm very big in the clinic on getting to know your anatomy. Not everybody's ready for this. However, if you are curious, what you can do is take a visual screen, okay? So items you'll need: handheld mirror, gloves or washed hands, and then your eyeballs. So the steps go, you wanna lay on your back, nice and comfortable. Knees are out to your side or butterfly, whichever you prefer, okay? Something comfortable. You take the mirror and you place it in front of the vaginal opening. You spread the labia apart and find the vaginal opening. So from there, you'll do a quick cough or a gentle bear down. Again, gentle is key. And you look for a bulge, okay? You can also repeat these steps in standing. Generally speaking, I'll have someone do that in the restroom where they can put a foot over the cover of the toilet or over the ledge of the tub. And what you're looking for, if you look on this screen right here, is a vaginal bulge. Where there's no bulge, okay, a mild bulge, you see something that may be peeping through. There is something at the vaginal opening, or there is a bulge, and definitely that does come out, okay? Symptom management. So with pelvic PT, we talk about coordination and training of your abdominals, your diaphragm, your pelvic floor. So kind of this canister that we have talked about earlier as well, and some core and glute strengthening to make sure that we keep everything up and in. Okay, and then we will go over some bowel and bladder habits. Some other things to take a look at is lifestyle and diet modifications. So decreasing constipation, because that decreases straining. Okay, the goal is to decrease the amount of unneeded strain in that diaphragm region to push everything downward. Okay, weight management, if that is a cause. And then looking at pressure management. So intra-abdominal pressure management of being able to contract the pelvic floor to fight all this downward pressure that comes on when we do lift and carry, when we do cough and stuff like that. Avoiding Valsalva maneuvers. So I put this little asterisk there because, again, Valsalva maneuver has their place in a lot of Olympic weightlifting, heavy weightlifting, and I'm not against all of that. It is just more of the coordination piece of understanding, can you get your abdominals and your pelvic floor to coordinate all of that before your lift to protect yourself, just as Q was saying in the last couple slides. So mechanical support, there are things out there such as support belts that you wear. They kind of look like female versions of jock straps that kind of help push up and give that perineal and pelvic region some support. There is something called a pessary. It's an internal mechanism that your provider OB can fit you for, something to talk to them about if you feel like that is something you need. And then there are some surgical procedures out there that, again, you can consult your OB about. Okay. Okay, give me 1 second. Oh. Sorry guys, internet problems. Okay, so next up, diastasis recti. We hear this a lot. This is essentially the separation of the abdominal muscles at the linea alba. So really quick, if you look at this right side, this is kind of a layered dissection of the abdominal muscles, okay? So first off, you have this thick fibrous tissue on the outside. You cut that back. This is your rectus abdominis. This is that six-pack muscle everybody talks about. And this is the belly button. Okay, and deep to that, you have your transverse abdominis. We have your internal and external obliques that help us side bend and rotate. Okay, now with a diastasis recti, this thick connective tissue right here is what separates. Okay, so the prevalence of a DRA, what we call in short in the clinic, is there was a study done that they found 27% of women in the second trimester had a diastasis recti, 66% in their third trimester of the pregnancy, and 36% remained after 7 weeks postpartum. So common thing we do see following pregnancy, just because there is baby is growing and the body kind of makes a decision of keeping it aesthetically pretty or allow baby to grow, and generally baby always wins. So that's also something to think about. So risk factors and causes, again, we talked about pregnancy, so multiple pregnancies, C-section versus vaginal delivery, as well as how big and heavy baby was during your pregnancy. And it depends on the person, because some moms are, 5'2" and have a 10-pound baby, and some moms are 6'2" and have a 10-pound baby. So everybody's genetic makeup is a little bit different. Heavy lifting is a really big one. We talked about intra-abdominal pressure management. Weight gain, weight loss is a big one. Repetitive heavy lifting, poor pressure management. So if you look at these two, this is a normal rectus abdominis, sorry. So everything's nice and pulled together and abdominals are by their side. Now, during pregnancy, again, we have to make room for baby. And with the amount of hormones that are rushing through the body, we look at the laxity of the tissue allowing fetus to grow. So you will see this, it is very common. Signs and symptoms are really low back pain. You'll see poor posture. People talk about this abdominal pooch that is low hanging or they can't get rid of. There may be a bulge, what we call doming or tenting, when you are in a sit-up position. So some moms will notice it when they have to get up really quickly from bed because baby is crying, and they'll see this bulge kind of lower into the midsection. You'll feel weakness in the abdominals, may or may not have abdominal pain or discomfort. Okay, so these are types of diastasis recti. They just kind of happen in different areas. Again, there's no rhyme or reason, just more so of lifestyle, habit, and then genetic makeup. So normal abdomen without a diastasis. So then you have diastasis at the umbilicus, which is just at the belly button, which is mostly the common one we see. And then you'll have one below the belly button. We have above it. And then there's one that runs the full length of the linea alba, okay? So self-screening. There's a couple ways to do this at home. I was trying to see if I can load the video, but I guess I can send a link out with it. So if you are looking to screen, what you want to do is you want to lay on your back with your knees bent and feet flat. So you want to be in this position. You're going to gently press down with your fingers. I generally tell people 2 fingers is nice. And I generally tell people from breastbone to pubic bone, because if you remember that diagram from before, our abdominals really run from like the base of where the bra is to right above your pubic bone, and attaches through the length of that. And from there, what we're feeling for is any tension and any softness. If you're like, okay, tense, oh, there's a little bit of sinking or a squishy feeling, I would say. That's somewhere you want to kind of keep in mind. From there, you gently lift your head, neck, and shoulders like she's doing a mini curl up right here. Okay, and it's gentle and really small. I tell people like 20, 30 degrees. You don't have to go into a full sit up. And then you want to feel if there is a bulge or a squishy piece. And then if you go side to side from the belly button, you'll feel the tension of your rectus abdominis. Okay, so we will look at, in PT, we look at the width, the depth, and the length. Okay, that'll kind of give us a little bit more information as to what's going on. Generally speaking, we do care about the width. However, we're really looking for depth. I would like, generally for patients, that after they leave me and they're done with PT, that they have a good trampoline feeling where the separation is, because that's telling me they're generating enough force to protect that abdominal region. So symptom management, again, we talk about pressure management, the breathing pattern that Q had spoken about at the end of her slideshow, as well as decreasing breath holding and Valsalva. And some women benefit a lot from using an abdominal binder. So that just early on postpartum, it just kind of helps hold everything together for some external support, because there is still the lifting and lowering that needs to happen. There is still breastfeeding that needs to happen, and life in general. So having some support might be nice. Strengthening. So we will also look at core, glute, and pelvic floor strengthening. So a couple slides back, we talked about how there's a big canister around this region. We've been talking so heavily on the pelvic floor. However, if you think about the sides of the can, they have to be intact and coordinated in order to keep everything upright as well. So we look at motor patterning of breath, core, pelvic floor, glute for certain functional movements. If there is return, we do some return to sport training. If there is a sport someone wants to return to, whether it is running or volleyball or whatever it is, we take a look at the movement science behind that and how to train you in that, as well as looking at functional movements. So we will talk about, in PT, we talk about bed mobility, transfer, lift and lowers, and activities of daily living. So knowing how to get in and out of bed correctly without aggravating your abdominals or your pelvic floor, understanding how to get in and out of a car, or lifting and lowering baby from either a bassinet, the floor, the crib, as well as daily activities such as loading and unloading the dishwasher. Okay, so those are some things that we do go over in PT. Okay, and I'm stuck again. Okay, sorry guys. Okay, so last thing to kind of go over is your transverse abdominis. I explain this as the deepest layer of the pelvic, of the abdominal girdle, and it holds you together like a corset. Okay, the fibers run this way, and the goal is to tension everything and close the doors. So something to try if you are somewhere, you can lay on your back, or you can do this in sitting. Okay, I want you to try to inhale first to relax the muscles. When you breathe out, begin to gently draw the abdominal muscles in as if someone was tickling you. Okay, envision your muscles moving inward and draw the belly button toward your spine. You may or may not feel a pelvic floor contraction, okay? And you can imagine zipping up a tight pair of jeans as you draw that belly back. Once the muscles are engaged there and you've drawn that belly button back, go ahead and take a normal breath for me, maintaining the tension through the abdominals. Some cues I usually give in clinic are, as you exhale, go ahead and do a shh. That generally will draw that belly in. Or think about blowing out candles. Get ready for your next birthday and really kind of drag that breath, purse your lips, and blow those candles out. And you should feel some tensing in the lower abdominals. To check if that is the case, you want to place 2 fingers below 2 inches below the most prominent part of your hip bone, okay? And as you exhale and draw that belly in, you should feel the muscle tense up underneath your fingers and pull away from it. So something to try. And we have progressions for all of that as well. And then lastly, okay. So I'm gonna, there it is. Okay, so lifting mechanics. So really quick, this is actually something I'm really passionate about for postpartum moms because of the amount of lifting and lowering we all do. So techniques to avoid are on the left. the one hip hold. A lot of times I call it the mommy hip. You prop baby on one hip. Usually it's your non-dominant side so that you can have your dominant hand to do things. And I tell people this is not wrong. It is just you don't want to be in that sustained position for a long time, because if you're propping baby into a hip, we're really putting weight and all of our stability through the hip joint, and you're really not working any muscles, as well as lifting with your back. So if you see mom right here, she's curved through, knees are slightly bent. It puts her lower back in a really precarious position to get injured. Okay, so this over here is one of those techniques we do work on, but again, we do modify depending on mom and comorbidities and past history of injuries. Generally, the goal is trying to stay in line in the spine. You don't have to be upright. I just care about people being in line and making sure you're using your hips and your knees to lift baby as you come up or down, okay? And then over here, last little tidbit is arching lower back. So a lot of the times, not even just with baby, but if there's anything heavy that we have to carry, a lot of times we throw it into our chest and we puff the chest up because we're sitting the weight into our spine, and that causes a lot of lower back problems. So thinking about when we carry baby, it's constant weightlifting. So they do get heavy. So making sure the abdominals are engaged and the glutes are engaged to make sure the abdominals, to make sure the lower back is not taking the brunt of it. And those are, again, some of the mechanics and things that we will go through in PT. Okay, so before I screw that up, I'm going to pass it on to Pizzy.